Hello, I'm a geriatrician working in Cardiff in South Wales, and I'd like to talk about really a 30-year journey to try and improve the way that patients are looked after following a hip fracture. Part of that work has been in developing orthogeriatrics, which is my full-time job, and I've been doing that pretty much full-time for 30 years now. But the other part of my role is as the lead for the National Hip Fracture Database in the UK, because we can't improve what we're doing for patient care unless we're measuring it, auditing it, and running quality improvement work with it. And the NHFD is a brilliant opportunity to show how that works. Can we improve the quality of care for hip fractures? When I started, all the arguments were, and they still are, about surgical care. There are huge numbers of research trials looking at surgical care of hip fracture. Huge numbers, huge expense, huge resources have gone into those. But it doesn't really matter. It doesn't matter whether you have a hemiarthroplasty or a total hip replacement if you've got one form of hip fracture. We've got good evidence from the health trial quite recently showing that. The anaesthetists get very excited as to whether we should do a general anaesthetic or a spinal anaesthetic. Some patients prefer one or the other, but I don't care what the anaesthetist does. It makes no difference to the patient in terms of their outcome, which sort of anaesthetic they have. The reason the surgical and anaesthetic trials aren't useful is that the quality of surgery is very, very good. The quality of anaesthesia is very, very good, and you can't improve usefully on very good. What we need to do is look for somewhere where care is poorer, where there are problems and challenges, and to try and improve care there. And that's a matter of looking at our patients, the frail, complex, often confused patients who come to us with hip fracture. There's clearly a lot that could be done and won't be being done as well as it should for them. And back in 2005, the British Orthopaedic Association and the British Geriatric Society, we met together to try and look at the ways in which we could improve the care in the UK. And we came to some conclusions which weren't at all about surgical care. They were about the way in which people's care was organised and aspects of the care that surgeons recognised that they weren't particularly good at. And these standards that were set have defined the way in which hip fracture has evolved since then. One of the things that we were able to do in England was to make sure that the money that hospitals get for providing this care is dependent on whether care is up to a particular standard. And something called best practice tariff was developed so that if your patient, a single patient, gets all 6 of these aspects of care, then the hospital got an extra €1,500 extra for that patient's care. And that incentive meant that automatically hospitals had to get geriatricians involved. They had to change the way in which care was organised. And that led to an improvement, a dramatic improvement in care. The criteria for payment have got more challenging as the years have gone past. We've added in other assessments, other requirements on care, and most recently this year, indeed in the last month, we've introduced the requirement that patients have delirium assessment both on admission and after surgery, because delirium is the most important and the commonest serious complication of hip fracture care. By having this financial incentive, we've seen a dramatic change in the way that care is provided. And as a result of that, we've had a number of papers which have documented the benefits and the improvement in care in the UK. England, this sort of financial payment is available. In Scotland, it wasn't. And this paper drew a comparison between the two and showed the impact of this standard-driven, audited care in the UK. The next thing that happened was that in 2011 we wrote the NICE guidance, the National Institute of Health and Clinical Excellence There's an organisation that looks at the best quality evidence. It looks at the cost effectiveness of treatments, not just whether they work, but how expensive they are and whether they are worth spending money on. And one thing we identified, the key thing that was identified in this, was that hospitals which had an organised, coordinated hip fracture program in their acute wards, delivering key aspects of care, showed markedly better outcomes than those which didn't. And this requirement for coordinated hip fracture programs was shown to save thousands and thousands of euros per patient. So it became the focus of attention in the UK. And we set up the National Hip Fracture Database as an online audit program, a quality improvement program, to try and make sure that these recommendations were fed back to hospitals so that hospitals could improve. And we developed a series of key performance indicators that measure the quality of care that a patient received. We've stopped looking at whether a surgeon did this or whether an anaesthetist did that, whether a physiotherapist gave a certain sort of treatment. And what we've asked is what the patient's experience is, whether the patient got the care that they needed. So our first key performance indicator was the patient going to see a geriatrician after breaking the hip, or were they just looked after by an orthopaedic surgeon? And over time, we've seen a dramatic increase in the amount of time that geriatricians spend with patients. And we've published a number of papers showing that the hospitals with the largest number of hours of orthogeriatrician time supporting their patients have the best mortality figures. So outcome has demonstrably improved in the UK as a result of this investment in orthogeriatrics. The urgency of surgery is a major topic for research, and there's a lot of controversy about it still, but the recommendation we made with NICE is that surgery should be done by the day after somebody comes into hospital, either as soon as they come in or by the next day. But nobody should have to have 2 nights in hospital with a broken hip. And you can see from this graph that this is 170 hospitals in England and Wales. You can see that there's enormous variation in how many patients get their surgery by the next day. About 2/3 of patients on average back in 2019 were getting surgery by the next day, but that varied from practically everybody in some hospitals down to practically no patients in others. After 2019, things got very complicated. One of the things we did with the NHFD was to measure how many patients developed COVID while they were in hospital or came into hospital with COVID. And that allowed us to monitor the pandemic using NHFD data. And at the bottom, you can see the waves of COVID infection as they happened. And you can see the mortality spikes, the extra waves of higher mortality associated with the first and second waves of COVID. What we're still seeing in the UK are quite high levels of COVID-positive patients in the hospitals, but happily with vaccination and the evolution of the pandemic, that's not translating into poorer mortality. But at the top of the graph, you can see that since the pandemic, we've seen an increase in the total number of patients presenting to hospital, the blue columns. We saw in December last year, we saw over 1,000 more patients than we were expecting across the country, reflecting the illness of patients, the breakdown of some health and social services following the pandemic, and just the pressure on the health service. And you can see that in the red line as well, that there's been a deterioration in our ability to get people to surgery quickly following the pandemic. So there's a challenge there, and the National Hip Fracture Database allows us to monitor it. It also allows us to monitor our third key performance indicator, which is whether patients get the right sort of surgery. And in the green line, you can see that across the UK, pretty much everybody now has cement if they have an arthroplasty. There's very few patients who are not suitable for cement, and really 100% of patients should be getting cement now. The purple line is more disappointing. The purple line suggests that surgeons continue to put nails in to trochanteric fractures where the evidence of the cost would very much argue for dynamic hip screws, and that's something that we're challenging at the moment. And then the yellow line is very interesting. The yellow line is the pattern of use of total hip replacements in some of the fittest and least confused, most mobile of patients. And what you can see over time is that there's been real fluctuation in how many patients get total hip replacements following hip fracture. And that's changed. You can see that when the health trial was published, questioning the benefit of total hip replacement, there was a reduction, a marked reduction in how many people got total hip replacements across the UK. That was more so following the pandemic. And NICE guidance has changed recently, and we've yet to see what the effect of that will be. Our fourth key performance indicator is whether people are able to get out of bed the day after surgery. Interestingly, in the UK, patients spend as long in bed, on average, after they've had their hip fixed as they do in bed waiting for surgery. So most people will spend 3 days in bed, half of it before and half of it after surgery. And that's clearly wrong. That's not good for people. Why they don't get up immediately following surgery is variable. 3/4 of people do get up by the next day, but 1/4 of people aren't. And reasons such as poor pain control, confusion, low blood pressure are quite commonly found as a reason for that. And one of the things that we've been pushing through the National Hip Fracture Database is asking for the anaesthetist to make a plan for transfusion, for blood pressure management, for analgesia, and to document that when people leave theatre, so that the junior doctors, the nurses on the ward, have a really senior opinion about what would be appropriate for blood transfusion and overnight fluid management and that sort of thing, to try and make sure that people are as fit as possible. It's a complicated topic. It's one that's covered in this, which is one of my YouTube videos. There's a sequence of these which I'll put up again at the end of this talk. But this just talks about the basic management of patients to try and keep them as well as possible through the perioperative period and allow them to be fit to get out of bed the next day. Another reason why they're not fit to get up the next day is that people become confused so frequently. About 1/4 of people develop delirium following a hip fracture. That's far more frequent than any of the surgical complications that people get excited about, bleeding and infection. Delirium is hugely important. If somebody becomes delirious, their chances of dying are increased by 2-fold. Their chances of needing nursing home placement, prolonged time in hospital, and then to go and live in a nursing home go up by a factor of 4. So this is a catastrophe and something that we need to be looking at. So the 4AT score, the screening tool to identify patients with delirium, is something that we're now using when patients come to hospital at the beginning. And we're repeating that score in the period following surgery to identify people who become delirious. And we're using a range of resources, many of these developed by Alistair McCulloch, who's the Scottish hip fracture audit lead, and whose whole pile of lectures and things are available on the internet from Alistair. Well worth looking at, because managing delirium is hugely powerful as a way of improving the care and the quality of outcome for your patients. If you ask patients what their outcome should be, what patients want is very clear. They want to get back home again. They want to be back in their old residence, wherever that was, as quickly as possible after fracture. And we will only know what patients achieve if we follow them up and ask them. There's very strong evidence that hospitals which actually follow their patients up and get good feedback data to discuss and to use in their audit meetings are much more effective and have better mortality figures. So sending questionnaires to patients to check whether they do get home again is really important. The other thing one should check is whether people are still taking osteoporosis treatments, as alendronate is generally not taken by patients unless they're given quite some support to do so. So following people up to check that they get home and continue medication is important. So we have this set of key performance indicators that we were using up till a couple of years ago, and we've now added 2 more to that list. The first we've added is an indicator to measure the care that people are getting when they first present to the hospital. Do they get a nerve block, and do they get out of the emergency unit and up to a ward where they can be looked after by the full MDT, the orthogeriatrician, the surgeons, the nurses, the therapists, all working together in a proper bed rather than being on a trolley in casualty. And is all that done within 4 hours? And again, this is the pattern of care across the country, and you can see that most hospitals are failing to deliver that for more than a few of their patients. So that's something we're really, really pushing to change, because early admission and the experience of people when they first present is frightening and can have a huge effect on their subsequent time in hospital. While people are in the ED, there are some important things to do: delirium screening, pain management, rehydration, and so on. But those need to be done fast, and then patients should not be waiting in the emergency department. They should get to the right ward as quickly as possible, and beds should be made available so that people can sweep up to the ward as quickly as possible. And then the final key performance indicator that we have, our 8th, is all about osteoporosis management. And again, you can see that across the country, most patients aren't on osteoporosis treatment. If you follow them up at 120 days after their hip fracture, most people are not on treatment. Within the NHFD, we can look to see what forms of drugs are being used for each patient. And again, these are all of the hospitals across England and Wales. And what you can see is that most of this page is white. The patient is given no treatment to prevent another fracture, even though we know that a third of them will have another fracture further on down the years. The grey area is alendronate, and I'm personally very sceptical about alendronate. Most people who are given alendronate are unable to continue taking it, so I think that's pretty ineffective. And what the NHFD has been doing is taking this group of patients who are at imminent risk of having another fracture, another fragility fracture, another hip fracture within the next months and a couple of years, and to make sure that they're on injectable forms of treatment so that we know that we can really make a difference to their prospects of future fracture. How we do that is targeted by Key Performance Indicator 7, and it's challenging hospitals to do it. But the simplest way to do that is to use intravenous zoledronate. There's a very good randomized controlled trial showing that works. It's very simple to do, and this, I think, is a very important paper which we published in Age and Aging last autumn, taking people through some of their anxieties about why zoledronate's difficult to use, and explaining how this can be done in a very simple form. And we think that we can double the number of people in the UK who are receiving zoledronate just by following these guidance. So we have a set of 8 key performance indicators, and I can look at these for my hospital and look at how my hospital's performing compared to the others in the country. These figures update on a regular basis, and that we can use those to drive quality improvement. And audits and quality improvement strategies are something that the hip fracture database website has a whole pile of different resources to explain to people. So we have huge potential to try and improve the care that we're giving to people. But I'd come back to final point that the quality of hip fracture care is not down to the care that we're giving. It's down to what the patient's experiencing. And it's important that we continue to think about what happens to the patient, what they experience, rather than what we think that we've done or tried to do. It's very easy to say, oh, I've done a falls assessment. But if the patient is unaware of it, or not engaged with it, or didn't trust it, doesn't follow it, it's not going to achieve anything. So we need to find ways of ensuring that what we do is important to the patient. And I think we should, if we're thinking about how we're improving care, we should look at what the patient's goals are for their own care. And I think there are 2. The first is that patients want to be made well enough to get out of bed so that they're not confused, they're sitting out, able to eat a proper meal by the second day after their hip fracture. So they have surgery on the first day, they're up with the therapist the next day. That involves us providing good anesthesia, good surgery, making sure they don't become confused, and good perioperative care. The second goal is that they want to be back in their own home, and they do want to be given protection against having another fracture. So we need to know that our patients have got back home. We need to follow them up to make sure that they are getting osteoporosis and able to take or continue on osteoporosis drugs. And that involves good quality multidisciplinary assessment, goal setting, rehabilitation, discharge planning. It involves us in doing bone assessments, getting people onto treatment, and following them up to support them in taking that. And I think if we have those two goals in our minds, we will develop better services and we will be more creative and helpful in the way that we develop services. And I'll leave you this. This is my YouTube channel, and there are a range of lectures talking about the key elements of orthogeriatric care, some of which I've talked about here. Key aspects of orthogeriatric care in short YouTube videos which are there for teaching purposes. Thank you very much.